Hello, my name is Marco Nievo and I'm the CSO of CTF Europe. I wanted to welcome you to this info masterclass and most especially thank you on behalf of all the patients for your interest in NF. Now, before we move on to the real stuff, I need to give you some instructions regarding the Q&A. You will be able to put down your questions by using the chat box during the masterclass. We would much prefer if you put down these questions in English. If you have trouble formulating your question in English, we could advise you to try to use online translators such as Google Translate before putting them down in the chat box. And if that is not possible for you, please do it in your own language, and we will do our best on our end to have it translated as best as we can into English. Enjoy your masterclass.
Dear audience, thank you for the opportunity today to present the webinar on neurofibromatosis type 1 from the pediatric perspective. I will introduce first myself. I'm a general pediatrician working at the Erasmus University Medical Center in Rotterdam, the Netherlands, and I'm leading the National Neurofibromatosis Center in the Netherlands. So these are my disclosures. So what I like to do today with you is to present some background information on neurofibromatosis and to discuss some specific NF manifestations in childhood. Next, I will guide you through the advices for child-specific surveillance and provide you some key messages to take in your mind after this webinar. So let's start to introduce the condition to you. So suppose a child of 8 weeks that presents with one cafe au lait spot with macrocephaly and a mother with a neurofibromatosis diagnosis confirmed. What would you think about his or her diagnosis? Or that other child that is 6 years old and presenting with delayed milestone and clumsiness. He needs to change from regular to specialized school. He's also characterized by a small stature, and when you examine him, he has 7 capital lay spots detected. Or that other adolescent of 14 years with a thickness of the cheek who is 2 times operated without success. She attends regular school but experiences difficulties, and she has some freckling and capital lay spots on the trunk. So in fact, all these are presentations of the variable condition of neurofibromatosis. The clinical features of neurofibromatosis may appear at different age periods. In fact, the condition is present from birth on, but at childhood, not all characteristics may be present and may develop in time. At infant age, mainly we see the cafe au lait spots. We may detect some dysplasia of bones like orbit, tibia, or pseudoarthrosis, and there may be plexiform neurofibromas present, but not always be detected. At school age, children are faced with learning deficits, and from the tumor manifestations of the pathway glioma may appear. And in adolescent, usually more skin lesions appear and the risk of malignancy is bigger up to adulthood. More specific, these are some pictures of the clinical manifestations, and you see the cafe au lait spots, the cutaneous neurofibromas, optic pathway glioma, bone problems, and the lesion only. The cafe au lait spots may appear in different presentations. They may be small and well bordered, but also they may appear a little more bigger on large areas of the trunk. Cutaneous neurofibromas may be present numerous or in small numbers. So the mechanism of neurofibromatosis is based in a mutation on the NF gene, chromosome 17. The protein neurofibromin is lacking, and it's interacting with the activation of the RAS pathway. And lacking this inhibitor, the pathway is more activated, leading to an increased cell growth and a change in cell survival. And this predisposes neurofibromatosis as a condition predisposing for cancer. Not all caveolus spots indicate the diagnosis of NF1. It's good to know that 1 to 2 spots appear in 10% of the normal population. And on the other hand, NF children may develop skin symptoms up to the age of 6 years. So even a child with a few spots may be at risk for NF. Also, there are other conditions characterized by caveolus spots, and it's good to keep those also in your differential diagnosis. Conditions like leopard, mono, bright, pebalism, or even a ring chromosome, which is very rare. Some diagnoses may be more important to detect, as well as DNA repair syndromes and NF2, with both a higher risk of malignancies, have caveolus spots as a characteristic. In addition to the regular characteristics, it's good to look also for minor features in NF1. We always say NF patients may look like each other. So children with NF1 may present with macrocephaly, hypertelorism, so the extended space between the eyes, are faced with hypermobility and reduced muscle tone, present with thorax abnormalities, may be small for age, and present with learning and behavior problems. And even those characteristics are not included in the real characteristics to define the diagnosis. They may help you to consider the risk of having that condition. So let's now turn to some more specific manifestations in NF1. An important manifestation in childhood is the presence of low-grade glioma, and in particular the optic pathway glioma. So children with NF1 experience in about 15 up to 20% optic pathway glioma, and it generally appears in the age between 0 to 6. Only a minority shows growth on MRI, and about half of them suffers from vision loss, proptosis, endocrine signs like puberty, early puberty, or the diencephalic syndrome. Only a small part of the low-grade gliomas in NF are non-OPG, as is shown by this figure. From the perspective of the whole population of optic pathway glioma, who constitute 1% of the CNS neoplasma in general, optic pathway glioma appear in 5% of all children, but NF1 patients constitute 60% of the OPG patients, and 80% is younger than 10 years. The mean age is 8.8, but it appears earlier in NF patients. The majority is asymptomatic, and the part that is progressive usually is female, has symptoms below the age of 2 years, and has the tumor beyond the chiasm, so the eyes here in the chiasm, and the tumors that appear also beyond the chiasm are associated with more progressive condition. So this slide presents to you the main diagnostic procedures for optic pathway glioma. Given the high risk on optic pathway glioma, we advise regular screening on vision to test vision fields, and there is a new technique, the optic coherence tomography, to detect changes at the retina and the nerve. MRI is the keystone for diagnosis of optic pathway glioma, but the results should be interpreted in relation to the effects on vision. And it's good to know that the majority is a pilocytic astrocytoma, so we do not advise biopsy. There is a dilemma in treating optic pathway glioma, as not all tumors give vision loss, and not all growth is associated with the effects on vision loss. So the MRI signs are not always related to the impact on vision and vision fields. On the other hand, we know that progression beyond the chiasm is associated with an aggressive tumor and vision loss. It's also important that for NF specific, we advise not to give radiotherapy given the impact of secondary tumors. Another important manifestation in childhood is the plexiform neurofibromas. They usually are present from birth on, but they may be small and become detected later on. Within the uncontrolled growth as a characteristic of NF1, we know that the tissue surrounding the nerve, like fibroblasts and neoplastic swan cells, are going to growth and that profile. And they result in large tumors that may be either visible from the outside, but also internal visible may impact the function of the nerve. In adult patients, we know that they are present in 50% of the NF patients, and they carry an 8 to 13 risk of development into malignancy, the malignant peripheral nerve sheath tumor. The majority of plexiform neurofibromas appear in the face and cause serious dysmorphology, but they also may be present in all parts of the body, affecting the function or cause complaints like fatigue, blood pooling, and motor dysfunction. And MRIs may show very extensive neurofibromas, like in this patient who developed the presence all along the thick nerves. You also see that they are growing very extended, and it's difficult, or in fact impossible, to remove them in total if they are present. The course of the plexiform neurofibroma is unpredictable, and this is an example of a small boy I saw when he was aged 2 years, and a few years later you see the increased deformity in the face that may be already detected at this young age. These are results from several studies on the growth of plexiform neurofibromas in age, and in general we assume that the growth is the highest in young children. On the other hand, we also see that in some older ages there is substantial growth present. Since recently there is a systemic treatment for plexiform neurofibromas. It's the MEK inhibitors that act in the RAS pathway. In a trial of Gross and Wiedemann they showed an admirable effect with an increased progression-free survival treating patients with MEK inhibitors compared to natural history. And this recently has resulted in FDA approval and EMA approval for the drug, although in Europe it's not for every country available. So let's turn to some other clinical symptoms in NF. They may be faced with endocrine symptoms, in particular small stature, in a small part that's related to the growth hormone deficit, but not all. It's also to do with the body composition, so usually NF patients may have smaller legs than the trunk. And there is a part of patients that show precocious puberty. This condition may be related to the presence of OPG, but also not always. But it's good to keep attention for growth and puberty during the regular controls. Bone effects are frequently present, and they constitute in a scoliosis, but also a congenital bone dysplasia, mainly from the tibia, or a sphenoid dysplasia. And I will present you some figures. So this is the scoliosis. For example, this figure is of the bone dysplasia. Sphenoid dysplasia is the absence of the sphenoid bone in the orbit, and that results to a lower position of the eye, and you can imagine that that causes also problems with the eye and sometimes tractions on the nerve. Often it's associated with an intraorbital plexiform neurofibroma as well, and it's the question which comes first, the presence of the bone dysplasia or the influence of the plexiform neurofibroma at that location. For the scoliosis, sometimes we see a real presence of a dysplasia of the vertebrae. On the other hand, it's also due to the hypotonia of the child that results in scoliosis. This is an example of a tibia dysplasia. Usually the bone is there, but in a dysplastic form, and it's less strong. The problem arises when it breaks, when it fractures during exercise, and the fracture is difficult to heal because the bone is abnormal. And sometimes it results in an amputation of the leg or otherwise in a long-term rehabilitation period. Another major problem in NF1 are the cognitive problems. We know that the mean IQ in children or also in adults with NF is shifted to the left towards a mean of 85 up to 90. We also see that an IQ below 70 is twice compared to the general population. In general, we say that the majority of children with NF1 needs special support during school attendance. In fact, in the Netherlands, we observed that 40% needs special education, 3/4 is 1 year or more behind, and 85% needs a kind of remedial teaching. Attention problems are frequently present in about 70%, but the real diagnosis of ADHD is in about 40%. Next are problems in visual spatial tasks and memory, problems in executive functioning like impulse control, social functioning, or logical thinking. Autism is present in a higher frequency, but also motor problems, speech problems, and fatigue due to reduced muscle tone are frequently present. And you also understand that if you have an IQ that's shifted a little bit to the left, like an IQ of 90, but it's combined with some characteristics of ADHD, and you have difficulties in executive functioning, it quite substantially affects your school performance. So it's good to assess all the problems as a whole and not to focus on one specific diagnosis like ADHD. In more show it, what you see is this is the mean. The red line shows the mean IQ for the general population, which is fixed at 100, and the curve shows the total cognition and the verbal and the performance IQ in NF population. And what you see is that they are all shifted to the left, and we come up to an IQ of 90. It's good, however, to understand that also higher IQs are present in NF population. It's only that the distribution is shifted. This is an example of the effects of impaired visual spatial learning in NF. We often test this by asking to copy this figure, either by having this in view or doing it without this picture. So imagine that you are asked to copy this figure, and usually when we start copying, we will first start with the general figures and then afterwards fill it in with the more details. However, if you ask an NF patient this task to do, they will start with, or they will end up with this figure. So they don't see the overview, but they will start with all the detailed aspects composing the whole figure. And this is a little bit to understand what's the problem in this condition. Let's turn to the advice of surveillance in NF1 children. So we have to deal with an incomplete phenotype, but also with an unsure future. Next, young age is faced with rapid changes. Children have a cognitive development and milestones, but also a change in body composition and puberty. And finally, parents are in the lead to ask for help and to support their children, but also they are often affected by NF. In Rotterdam, we have the Encore NF1 clinic, and what we do is that children are annually viewed by a combination of a pediatrician, a child neurologist, and an ophthalmologist, and be on annually after the age of 10. Geneticists to advise parents is always present on call, and we perform neuropsychological evaluation at standardized ages. Geneticists to advise parents is always present on call, and we perform neuropsychological evaluation at standardized ages at 3, at about 6 years, 11 and 15 years, and these are the key ages where children usually change from different school types. There remain perhaps some questions on what to do with imaging screening in NF, and in general we say you should not do it, but to do it on indication. An example is that the whole body MRI technique is now more frequently present, and given the fact that we know that internal nephromas are present 50% in NF, and that the tumor load is predictive to MPNST risk in adulthood, you may consider this as a valuable technique. On the other hand, we see that these risks are more present in adults. So a whole body MRI is not included in the general approach in childhood and may be considered at adolescent age. For cranial MRI, I know that there are also centers that regularly screen cranial MRI, regular screen children with NF by cranial MRI to detect OPG. But the question is what you do with observations of stable OPG without symptoms. And I explained also is that the choice for therapy depends on the symptoms. Next, there's also a lot of manifestations that can be seen on MRI but do not have clinical consequences like phases or neubos, in particular in the basal ganglia. So in that sense, to screen by MRI may be more contributive, in particular in those children older than 2 years who have unreliable ophthalmologic exams, or very young children, given that they have a little bit more risk on the development of OPG. Other screening for other conditions, there is a small increased risk for juvenile myeloid leukemia in children, but the risk is still very low. There is reported in literature an association with the presence of xanthogranulomata, but on the other hand, we think that you should not screen by blood testing for this condition, but with regular exams to look for general symptoms like anemia, hepatosplenomegalia, or increased lymph nodes is sufficient. Another condition is osteopenia or osteoporosis, which is more prevalent in NF1 and associated with increased, and is also increased in presence of reduced exercise and fatigue. And in that sense, we think it's valuable at least to optimize the vitamin D status. So in general, we say for NF1 we need multidisciplinary care, as it is a genetic disease with variable presentations of symptoms, in the number of symptoms and complications, but also on the moment of the occurrence. And there is no association to predict the symptoms based on other characteristics. It affects the development of the child at various ages, delayed milestones, but also on behavior and cognition, interferes with school and learning. And it affects the adult in participation in society by having a genetic condition, having an increased risk risk of malignancy of morbidity, but also it affects work and social function. So the key messages for NF1 is that it is a condition for lifetime, but highly variable presentation. It needs a follow-up of the incomplete cases in childhood. Multidisciplinary follow-up is essential, and complications require a specific management. There is no routine imaging indicated, but we may discuss a whole body MRI at the end of adolescent and MRI screening of the CZS. So thank you for your attendance, and I also would thank the collaboration of my colleagues at our local center, but also national and international. And I'm happy to answer some questions.
Hello and welcome back. Welcome, Rian. Thank you very much for your very extensive review of all the very many manifestations of children of NF1 in children. You are receiving many thank you messages in the chat, but as at the moment I can't see any real questions coming up. Yes, the first questions comes from Luigi Barlassina. And what kind of tests or screenings should neurologists perform at yearly visits, at every yearly visit?
We usually apply the regular neurologic exam. So the reflexes, but also sensibility disturbance, and also when I was replying, I was doubting whether you also would like to know about the neuropsychologic testing, but I assume you only want to know about the physical neurologic exam. So I think this reply covers it.
Another question from Carlos Lopez. What kind of physical therapy is needed after a surgery and is necessary after the removal of a big neurofibroma in the back, for example?
Well, I must say, first of all, surgery is the only option until now, but it's not regularly performed. So in that sense, my response is not based on a large number of patients. The key issue is if there will be damage to the nerve or to the surrounding tissue. And in fact, debulking is aiming to preserve the function. So in that sense, it's more focusing on recovery itself. So I'm not sure where you're further referring to on supportive therapy in that sense, otherwise than the regular, unless you expect that there will be damage or focal deficit. But
another question from Carlos Lopez again. They're asking if it's possible to use hormones for growth problems.
Okay, so you mean the growth hormone therapy for short stature? Yeah, well, that's a good topic. So there are lots of children in NF that have a shorter stature, and usually that's not due to hormone deficiency, but it's just due to the changed body composition, so that the legs are a little bit shorter, as we see also in conditions like Noonan. And what you see then is that the children will have the same pace of growth as their peers. So in that sense, you won't expect a growth hormone deficiency. There is a small group that has indeed a proven growth hormone deficiency, and in that group, we consider indeed that growth hormone replacement therapy can be performed also in NF patients. Of course, there is a debate on whether growth hormone may induce cancer in a condition that predisposes for developing cancers. But well, based on literature we have, is that if you have a proven growth hormone deficiency, replacement to normal levels of growth hormone won't increase that risk. Of course, there is the debate on whether you would treat, for example, children that have normal growth hormone values, but have an indication for growth hormone. And I think that's per country very different. So in the Netherlands, we have an indication, for example, if you are small for gestational age, and then you have an indication also for growth hormone treatment. I must say we have dealt with a few cases in our population on this particular combination, so neurofibromatosis and small for gestational age, and we thought that the risk of inducing cancers due to growth hormone would be too high, so we refrained from replacement therapy. But it's not proven.
But do you have a higher number of kids who would require, I mean, who have this hormone deficiency in the NF1 population with respect to the general population? Or
yeah, it is a known complication, and in that sense, it's advised to, in the regular checkups for NF1 children, to monitor growth and growth pace, and if there is deviation of growth, and in particular also if you see that the bone age is retarded, that you perform studies to prove growth hormone deficiency. Yeah, so it is indeed a monitoring aspect.
Thank you. Another question from Sandra Toel. Do you make genetic analysis in very young children with isolated café au lait spots, or do you wait for a second criterion?
It depends. Well, first of all, if the parent have a proven mutation, the discussion, I think, is not so difficult. And usually the parents then ask also to perform that test. But suppose the child that would be the first in the family, so you don't have a familial mutation known, it depends a bit. I usually take first the number of abnormalities, so the number of café au lait spots, and either if there is an additional sign, but also the minor features as I shown, like macrocephaly, the thoracic abnormality. So in fact, the criteria that do not contribute to assess the clinical diagnosis, but we know that they do occur more frequently in NF patients, may help you to decide to do that. And I think a third criteria to consider diagnosis is also what's the question for care of the patients or of the parents. So if you have a child that is developing different from the normal child, so you have a question on explanation why this child is doing this development, I think you would lower the threshold to do diagnosis versus a child that is doing well and don't have any problem. On the other hand, I think if you refrain from diagnostic testing, you should also make sure that you have a follow-up period, and we usually advise at least to review those children at 6. And the last point I want to say is it's important to consider also that a negative DNA result doesn't exclude the diagnosis NF, because we have 5% of the patients with NF we can't diagnose by DNA. So in fact, I think you have to decide before you decide test what will be your follow-up and what's your level of suspicion on the diagnosis. So I usually try to do it before making a plan, and then figure out if doing the test and having the result will change that approach. And I discussed that with parents. Well, and perhaps that may make that you decide differently in 2 similar cases.
Thank you. We have another question relating to follow-up from René Soudan. It's a good question. Why does every country have their own way of follow-up? it's important in René's view, and certainly in mine, that the follow-up should be done, roughly in the same way in all countries. And she wonders whether there's a European Council who deals with this uniformization matter.
Yeah, well, we're working on it. Thank you, Renee, for this question. I think I know you. And we are working on a European level with a European guideline for NF, but it's not finished yet, so I didn't include it today. And it's focusing on, in particular, on tumor management, so not on all the aspects, although we will try to develop European guidelines for those aspects as well. Another issue I think it's important is that a guideline, or at least the frequency of follow-up, is also dependent on how easy patients get access to what kind of healthcare. So if we describe intervals of control visits, it's good to understand if patients have easy access in case of urgency questions, or that they have difficulties to outreach to NF experts. So in that sense, I think there always will be a little variation among countries because of the organization of healthcare.
Now we have a flurry of comments and questions regarding MPNST. João Passos mentioned the fact that he recently had a case of an 11-year-old with an MPNST, and he likes to think that an earlier diagnosis could have changed the terrible outcome of this. And now they tend to do full body MRI on all patients regardless of this.
Well, first of all, I must admit I'm a general pediatrician, and in pediatric patients with NF, we fortunately do not see that often MPNST, although it's a known complication, so the experience is not that large. But it is still occurring, and it's good also to mention this. So that's why we always check for the alarming signs and instruct parents. The role of the whole body MRI is a difficult one. Well, first of all, we have proved that the tumor load in the body, so not in particular, so the role of the whole body MRI is more to detect the tumor load rather than the presence of an MPNST. And we know that the tumor load at adolescent age, so at about 18, has been proven to predict for the development of MPNST at older age in adulthood. So in fact, there is no association between tumor load detection or assessment and the presence of an MPNST in childhood. A next issue is that whole body MRI, of course, screens the whole body, but with a certain thickness of slices. So you may have even an MPNST smaller than the slices and you don't detect it. So it's not a guarantee to detect it. And in fact, the whole body MRI itself will never give sufficient pictures to determine in itself if to differentiate between an MPNST and a plexiform neurofibroma. So those are considerations when I look back in our group dealing with the guideline for tumor management in NF I was referring to in the previous question, that we do not put the whole body MRI as a central element for monitoring in childhood. And the difficulty is always that it's good to be aware of those cases that people experience, that sometimes detection could have been earlier. But I don't have a direct answer on it, and I hope I have put it a little bit in perspective.
Still on the MPNST theme, Jennifer Brault would like to know, what do you discuss with parents to monitor for and report to you for early detection of the MPNST?
Yeah, that's also an interesting question, because also in our European group, there was a debate on whether or not we should instruct parents on alarming signs of MPNSTs if they do occur rarely in children. So are you more making them scared, or do you instruct them properly? On the other hand, I think the complications of NF never occur when the patient is in front of you, but always in the interval between two control visits. So it's good, I think, to instruct patients. And in that sense, I think it's also part of the education, and to make sure that they will be compliant for follow-up, to explain what are alarming signs or red flags and how you name it. And in that sense, well, I think for MPNST, or the development of a plexiform into an MPNST, is always the symptoms like pain, and not pain for a short period, but persistent pain that it cannot be explained by common other reasons. A change in texture of the tumor, or a very rapid growth. But we also experience that if we instruct patients in that way, that they will often contact for these reasons, and that you can review them, and they won't have any real sign of the malignancy. But anyway, I think, well, that's in the game of monitoring this condition. I mean, there is a risk, and we know the risk is increased. So I think the risk factors I named may be helpful, and it's good to check with the parents or the patient himself if he understands those risk factors, where to look for, and how they understand them and how you apply them.
Another question coming from Marek Karwacki regards whole body MRI. He says it's really reliable, but it may miss out on small tumors and not give the precise overview. On the other hand, you can detect some tumors by CNS MRI. So what's your position here? So they tend to decide not to perform whole body MRIs, but rather more focused ones. And I would like to have your opinion on this.
Well, in fact, I fully agree, and I think it's a good summary of also the discussion we had in the European group. Well, so I agree with what you say. Yeah. So we don't screen in childhood by whole body MRI. We focus on specific symptoms and signs during physical examination and patient history, and we do specific MRI for parts of the body in more detail if we have a high suspicion.
A question from Luigi Barlessina. It says, in some countries, the neuropsychiatric assessments are made yearly, rather than the schedule you presented. So what is your rationale for this? And is there any consensus on the value of psychomotor therapy for NF children?
So with regard to the neuropsychology testing, I think it's also a balance between what's feasible in your center, also what's feasible in your healthcare organization. Also, when you think about, sorry, I lost the word, the financial aspects, because it's not always included in, I know in health insurances in all countries. Well, the program we perform in the Netherlands is a result of a start we made, I think, 15 or 20 years ago, and we applied this method in a group of neurocognitive genetic conditions, so not only neurofibromatosis but also other conditions like TSC and Angelman, and we stay to this because these are the years that in the Netherlands the children change from school type. So 3-4 years when they start at primary school, then they enter after 2 years in a more learning phase, and often more learning disabilities appear. And at 11-12 they change to secondary school and the age of choosing for your professional education. But of course, doing it annually, well, I can't say why you should not, but I think it's a balance between the profits and the drawbacks, like burden for the patient and the organization to do so.
And Marek comes back with another question on MRI. How often do you make MRI in children with a suspect of MPNST, but which have a confirmed atypical plexiform, which has not yet transformed?
Oh, that's a difficult one, because in my experience, I do not have a patient in that sense. I usually follow these children up in close collaboration with the oncologist, and in the Netherlands, that's centralized, so the oncologist in charge is not in our center. I think it's good to understand that MRI only is not sufficient to differentiate between malignancy and benign. So there comes also the PET scan in. So additional to your question, I think I could add, what's then the position of the PET scan? And I think a combination of this combined also with perceived progression or change in the tumor or a change in the complaints will guide you to the intervals of imaging. And I think for that tumors, there is not a real protocol to be set. So I hope this answers your question.
Yes, Marek mentions the fact that he is a pediatric oncologist, but just for you to know.
I know, so I was careful with my reply, but it's good to have a discussion on this.
We have a question from a parent. Would like to know if his child should be getting regular dental X-rays, or if they should avoid these as much as possible.
Well, that's a good question, because in fact, being a predisposing so tumor predisposing condition, you should be careful for unnecessary radiation. So in that sense, I think it's good to consider whether you should or you should not do those techniques for screening. If you look for the perspective of increased dental problems in NF, there are different publications. So there are publications that state that there are more dental problems or jaw problems in NF patients. It's doubtful whether it has to do with other underlying conditions rather than a specific NF. So I'm not sure what you mean, what's the reason behind this question, if it's focusing on specific problems, dental problems in NF, or that you more mean that you're used to do regular screening by radiation, dental radiation for all children.
I can't
I'm
see.
not sure if they're.
Jackie says radiation exposure.
Yeah, okay. So I would be careful. Yeah.
Sorry, I'm scrolling down up and down the chat because yes, there was a question from Diana Nichols. We ask if flat feet can come with NF1, if they can be, if they're more frequent in NF1 kids, flat feet.
Oh, flat feet. Oh, sorry. Yeah. Yeah. So the pes planus, as we call indeed. Yes, you see. So children with NF have a reduced muscle tone, resulting often also in hypermobility, and in particular young children, but also up to adolescent, you always see higher frequency of flat feet. Problem is always what you need to do with it. Well, hypermobility usually will reduce a bit when you grow older. So in that sense, the problem is sometimes getting less. But on the other hand, you cannot correct it. So I usually more look for what are the complaints secondary to it. So if there is a reason that the child then has a problem with walking, or has what's the English word, cramps in the legs, for example, because they use the muscles differently, and they stand different on their feet. Well, it's worthwhile to support by special shoes, or sorry, I really don't know the English word for that. So you have some inlays in your shoes. Yeah, that's the word. Sorry. And but I think you have to not to do that as a to try to correct the problem. It's more to look for what's the resulting complaint for it, and can I reduce that by an intervention. I think that should be leading in whether or not doing anything for it.
Great. There's a flurry of questions and thank you messages. And we have another question from Roya Mostafavi. Do you have any recommendations for evaluation and monitoring of rare complications of NF1 like moya or renal arterial stenosis?
Yeah, because that was a bit not so clear probably in my presentation, indeed, because they are rare. So first of all, we do not screen for it for vascular abnormalities in NF. However, for renal vascular stenosis, the symptom is hypertension. So measuring blood pressure is part of the regular visit, control visit in NF. And I think, well, I have a few cases indeed that we detected those, although there is also essential hypertension occurring in NF1. And for the others, I must say we do not regularly screen for vascular changes in the cerebrum, like the moya. And yeah, there will always be a case indeed that has suffered from problems from that, and we are aware of that.
Yeah. Now, Dulces in Fundo, a question from Marek. How do you manage transition from pediatric to adult care? Which is a very, very good question.
Yeah, thank you very much. Well, perhaps we may have a webinar specific on that another time, but then with a few colleagues. Because I think, well, when I talk from the Netherlands, the monitoring and follow-up is well developed for children, but only I think since 10, 15 years, it's more structured also for adults. And we see that problem in more countries. So in the Netherlands, we usually do the transition between 16 and 18 years, but that always depends on the healthcare system, because there are some countries where it's used that patients go in transit to adult care at 16. So I think the advice is on that also. When some people state 16 or 18, I think you should translate that to the situation in your country and not to that strict age itself. What we do is that we try to together with the one who's performing the childhood care up to then, and so that's so that they get in touch, and that they get known about the next carer. We include a genetic consultation, a kind of a repeated genetic consultation that will focus on the genetic aspects, but also the inheritance and the issues in when to discuss or to come back, and how to inform a partner in future on that condition, etc. So those aspects we offer around that age neuropsychology testing as well, to consult patients on and also to see if they need to be educated from the psychological part on their condition, but also to prepare for for their adult age in terms of participation in society and work. And usually I send them also a small letter with a summary of topics and appointments, like that they should measure the blood pressure to the GP, some red flags, etc., and some information sites. And it also depends on the structure of the adult care, how it is in your country. So I know that in some countries the follow-up is led by the primary physician, and in some other countries it's hospital care. So in that sense, I think you have to look also what's used in your country, and how to inform the patient to make sure that he can deal with it, because I think that's the most important part. That in particular in adulthood, the patient needs to be in the lead for arranging the follow-up and knowing where to go, where, when, and well, it's a question if all patients with NF can do that with the complications they experience, and how you could or should support them.
And another question from Joao Passos. Do you consider Moya screen in patients treated with radiotherapy?
Oh, I must say, we try to avoid radiotherapy in NF patients due to the induce of secondary tumors. So in our population, I can't remember one in that sense. So I think I should leave blank. Sorry.
Yes, Joao actually mentions the fact that that this patient must have been treated with radiotherapy because of her abdomen.
For some tumors also in NF patients for it. And I think it's a good consideration that sometimes a specific treatment may induce secondary complications, and you may be aware of it. But in that sense, I can't advise on a regular approach in that sense.
But there is a general understanding that if a patient for some reason has received radiotherapy, the follow-up should be more intense and enhanced and directed to the fact that that patient has received radiotherapy.
Yeah, I agree with that. But if you ask my general opinion, if you should do that on all patients, I think I should leave blank based on the experience until now I have. And I think we better then should pose it to an expert on that topic. Yeah, although I agree what Marco also said and what's posed in your question.
Okay, I think I have taken all the questions from the chat. Thank you everyone for having made this session very, very lively. I see people are chatting amongst them in the chat separately and giving advice, and it's very nice to see this happening. There was a question regarding the possibility for attendees to come up live. Currently, it is structured this way. We may consider in the future to have people come up live with questions. But we hope you understand that with many attendees, there's been a peak of about 58 people today. With many attendees on the screen, it can be very difficult to manage. And this is the reason why we do it via the chat box. Thank you very, very much, Rianne, and the attendees for this very nice session. If you want to go back to this session, we should post it on the INFA YouTube channel in about 10 days, I hope, in all 7 languages. And And the next masterclass is on February 17th, and it's on neuropsychological issues. And thank you again, Rianne, and I hope to see everyone back soon.
Thank you for hosting. Bye.
Bye.